My name is Alex Nichols, and my pediatric in-service is over Dupilumab, or brand named Dupixent, for moderate to severe asthma. The learning objectives for today are to briefly review current treatment options for asthma management, explain Dupilumab's mechanism of action and administration recommendations. Then we will analyze the available clinical data on the efficacy of Dupilumab for asthma management. Finally, we will apply our knowledge to a therapeutic patient case. Current therapy for asthma works in a stepwise manner. This chart is from the EPR3 Quick Reference Guidelines. You can see that it's broken down by age and the step of therapy that the patient qualifies for based on symptoms. In general, we start from a SABA as an albuterol inhaler or nebulizer. If further symptom relief is needed by staging a patient or stepping up therapy, an inhaled corticosteroid, like an ICS, is slowly increased in dosing. We can also continue to add in combination a LABA, such as salmeterol or formoterol, in conjunction with that ICS for further control. These medications are known as controller medications and are intended to be taken daily, in contrast to the emergency nature of albuterol, which is PRN. These controller medications are going to decrease that underlying inflammation found in asthmatic patients. Corticosteroids are a last-line add-on to maintenance therapy, but can also be used for exacerbation management. Adjunctive therapies, such as monoclonal antibodies and immune modulators, can be used for further control. Dupilumab is an adjunctive therapy used in asthma management. Its mechanism of action is as a human monoclonal IgG4 antibody that inhibits overactive signaling of interleukins 4 and 13 by binding to the IL-4 receptor alpha. This inhibition reduces the cytokine-induced inflammatory response and subsequent release of IgE. Dupixent is novel in its targeting of both IL-4 and 13. In pediatric patients, Dupixent is indicated for moderate to severe asthma, specifically that eosinophilic subtype. Eosinophilic asthma is responsible for up to 60% of severe cases, but in the population as a whole, it only comprises about 5% of all diagnoses of asthma. It is specifically marked by elevated levels of eosinophils in the patient's blood. An additional pediatric indication for Dupilumab is severe atopic dermatitis. Dosing for pediatric patients 12 years and older is as an initial 400 mg subcutaneous injection, followed by twice-monthly 200 mg injections. Patients who present with severe symptoms can alternatively be dosed under an initial 600 mg bolus with twice-monthly 300 mg injections. It's important to note that the splitting of the initial dose will be as 2 separate injections, but given at the same visit, and they can also be given at home. Dupixent's place in therapy is as an adjunctive therapy for moderate to severe eosinophilic asthma or asthma dependent on oral corticosteroids. Dupixent is given as a subcutaneous injection to the thigh, abdomen, or upper arm. It can be administered at home. Though it's stored in the refrigerator, you should allow the dose to come to room temperature before injecting. The pre-filled syringes can be stored at room temperature for up to 14 days. Remember to rotate injection sites for each dose. In the case of a missed dose, administer as soon as possible if it is within 7 days of the scheduled injection time. If it's been more than 7 days, wait until the next scheduled dose and then resume on the original schedule. Side effects to monitor and counsel for include injection site reactions, oropharyngeal pain, eosinophilia, and conjunctivitis. However, increased risk of developing conjunctivitis is associated with patients undergoing treatment for atopic dermatitis versus asthma in the clinical trials. Here you can see the raw data for the safety endpoints in the Dupixent trials we will discuss shortly. The primary reaction is injection site pain at about 14 to 17% of patients, to include symptoms of edema, pain, and inflammation. Other significant reactions are that oropharyngeal pain and eosinophilia, occurring in about 2% of patients respectively. Cost for this medication averages about $43,500 per year, and there are payment plans through the drug manufacturer Sanofi. 3 large-scale, multi-centered, randomized, placebo-controlled Phase 3 trials were conducted, contributing to the FDA approval of Dupixent for asthma. Together, these trials enrolled 2,888 patients for Dupilumab or placebo therapy. In Trial 2, known as the Liberty Asthma Quest, assessed the rate of exacerbations and change in overall lung function for patients 12 years and older with uncontrolled asthma using Dupilumab 200 mg, 300 mg, or placebo therapy. Trial 3, or Liberty Asthma Venture, assessed the reduction in oral corticosteroid use dosed from baseline to week 24 while maintaining asthma control for this oral corticosteroid-dependent asthma in patients 12 years or older with severe asthma when using Dupilumab 300 mg or placebo. To note, there are ongoing studies to seek approval in those 6 to 11 years old, and adult indications have been approved separately from pediatric patients for rhinosinusitis with nasal polyps. So let's break down that Liberty Asthma Quest study. Remember, this was the largest of the 3 phase 3 trials that Dupixent underwent for approval in asthma. The study population included 1,902 patients aged 12 years and older with uncontrolled asthma randomized from May 2015 to September of 2016. The drug intervention was Dupilumab at 200 mg, 300 mg, and respective placebos in a 2:2 to 1:1 ratio for a total of 52 weeks. The authors were looking at rate of exacerbation and absolute change in FEV1 as their primary endpoints. For rates of exacerbation in the Dupilumab 200 mg group, it was found that the rate of exacerbation was about 47.7% with Dupilumab versus placebo. In the 300 mg group, the exacerbation rate was about 46.5% lower than placebo. These results were noted to be statistically significant in the author's conclusions. Subgroup analysis was also performed, and it showed that reductions in exacerbations was higher in patients presenting with elevated levels of eosinophils at baseline, and this elevation was denoted as greater than 300 cell count per millimeter cubed. For absolute change in FEV1, the 200 mg group showed a 0.14 liter change, and the 300 mg group showed a 0.13 liter change. So this resulted in up to a 33% change versus placebo when patients were on Dupilumab. Secondary endpoints for this trial were combined exacerbation rates, FEV1 in patients specific to high eosinophil levels, and ACQ-5 scores, which are a measure of control of symptoms. Here in this slide, you can see the results from trials 1 and 2 of Dupilumab's phase 3 studies. I did not discuss trial 1 as it pertains to those that are 18 years or older, contributing to adult indications. However, in trial 2, you can see the raw data from the summary I just gave on exacerbation rates and FEV1 function. This chart also illustrates the subgroup analysis that was performed as patients presenting with elevated baseline eosinophils had significant changes in primary outcomes versus those who did not have elevated eosinophil levels at baseline. So looking at this medication in general, we are seeing a dual targeting drug specific to the inflammation that's promoting asthma severity and reducing overall control with normal maintenance medications. In the clinical data, we saw large-scale randomized trials showing reduction in exacerbation rates by 46% and improvement in FEV1 function by up to 33%, as well as a reduction in oral corticosteroid use. This last finding resulted in approval for those 18 years or older, but the previous 2 are indicated for those 12 years and older. Therefore, I would recommend the use of Dupilumab in patients with moderate to severe eosinophilic asthma as add-on therapy. So for the last learning objective, we're going to take a look at a patient case and review some self-assessment questions. Charlotte is a 16-year-old girl with a past medical history significant for eosinophilic asthma and seasonal allergies. Her current medications include loratadine, 10 mg daily, an albuterol inhaler, PRN, Flonase, 50 micrograms, 2 sprays in each nostril once daily, Advair Discus, 250, 500, 1 puff BID, so that's going to put her at a high dose ICS plus a LABA. Then prednisolone burst, PRN exacerbation. So the patient is currently taking 30 milligrams twice daily due to a flare-up, and she'll be taking this for 5 days total. And Charlotte is now presenting to clinic for follow-up due to worsening of symptoms during her corticosteroid burst, and this is her 3rd exacerbation this year. Given this information, would Charlotte qualify for treatment with Dupilumab? Yes, because she has uncontrolled eosinophilic asthma with frequent exacerbations requiring adjunctive therapy. No, she requires step-up therapy to a high-dose ICS plus a LABA plus or minus Xolair therapy. No, she should continue with long-term corticosteroids and begin nebulizer therapy. Or yes, she has a severe asthma and should start Dupixent injections weekly. Secondly, which of the following counseling points would you emphasize to this patient? Allergic reactions, GI upset, asthma exacerbation, or conjunctivitis? Some more questions to consider while counseling this patient. What is the route of administration for Dupixent? IM, sub-Q, IV, PO? Also, is this a medication that they can take at home? Do they have to be in the hospital? Can they come to clinic? And then lastly, after reviewing available clinical data, which of the following is true of Dupilumab therapy? It reduces asthma exacerbations, increases lung function, reduces the use of corticosteroids, or all of the above. So here are the answers to the self-assessment questions, and if you have any questions about these, please feel free to email me at alexandra.o.nichols@ttuhsc.edu, and I thank you for your time. If you would like to further investigate Dupilumab therapy, I've included my references from the clinical trials and information presented here.